Positioning Lesson 9 is the cervical spine. The cervical spine is one of the most critical areas of the body to image correctly, and one of the most commonly tested on the ARRT. It requires at minimum 3 projections, has specific trauma protocols, and includes anatomy and measurements that carry direct clinical significance. 14 minutes. The cervical series begins with 2 AP views, one for the lower cervical vertebrae, and one specifically for C1 and C2. AP axial cervical, C3 through C7. Patient supine or upright, true AP with the mid-sagittal plane perpendicular. CR, 15 to 20 degrees cephalic. That cephalic angle opens the intervertebral disc spaces by aligning the beam parallel to the cervical disc planes. Center to the thyroid cartilage, the level of C5. KVP, 70 to 80. Grid, yes. Chin elevated to keep the mandible out of the upper cervical field. Demonstrates vertebral bodies C3 through C7, intervertebral disc spaces, and unsinate processes. AP open mouth, the odontoid view. Purpose, see the odontoid process, the dens of C2 between the C1 lateral masses. Patient supine, mouth wide open during the exposure. CR, perpendicular, centered to the open mouth. For proper positioning, the upper incisors and the base of the skull, the occiput, must be superimposed. This confirms the CR is truly perpendicular to the C1, C2 level. Demonstrates C1 atlas, C2 axis, the odontoid process, and the atlantoaxial joints. The lateral cervical is the most clinically important single view of the cervical spine, and in trauma, it is always the first film obtained. Patient upright, seated or standing, true lateral. The arm nearest the tube is depressed, or the shoulder is pulled down by having the patient hold a weight. This moves the shoulder girdle inferiorly to uncover C7. SID, 72 inches. The long distance reduces cervical magnification. KVP, 70 to 80. CR, horizontal, perpendicular to C4. Collimate to the cervical region. Evaluation. All 7 cervical vertebrae must be visible, C1 through C7, with the C7, T1 junction included. If C7 is not visible, a swimmer's lateral is required. Vertebral bodies superimposed, true lateral. Intervertebral disc spaces open. Zygapophyseal joints visible. Prevertebral soft tissue visible and measurable. Trauma lateral, cross table. Patient supine, do not move the head or neck. Beam is horizontal. IR placed against the lateral side of the patient's head and neck. An assistant gently depresses the shoulders by pulling on the wrists. Must demonstrate all 7 cervical vertebrae plus C7, T1. Swimmer's lateral. One arm raised above the head, the other depressed. CR, perpendicular to C7. T1, 15 degrees caudal may help. Penetrates through the shoulder girdle. Ishi, 40 inches. KVP, 80 to 90. 2 more cervical projections, both with specific diagnostic targets. Oblique projections. Purpose, demonstrate the intervertebral foramina, the nerve root canals on each side of the spine. For obliques arretin, repo, little, o, leo. The patient is rotated 45 degrees from true lateral. Posterior obliques, PA projection. Demonstrate the foramina closest to the IR. Anterior obliques, AP projection. Demonstrate the foramina farthest from the IR. CR angle. 15 to 20 degrees cephalic for AP obliques. 15 to 20 degrees caudal for PA obliques. This angle opens the foramina by aligning the beam along the oblique plane. Ishi, 72 inches uprig perforat. Center, C4. The obliques demonstrate the foramina on the side being imaged. Flexion and extension laterals. Purpose, demonstrate ligamentous instability or subluxation. Patient upright, voluntary flexion and extension. Never passive manipulation. The patient moves themselves, the radiographer does not move the head. Flexion, chin toward the chest. Extension, chin raised. CR, horizontal, perpendicular to C4. All 7 cervical vertebrae demonstrated in each position. Order 4. Rheumatoid arthritis, post-trauma clearance, and suspected instability. 5 anatomy and measurement concepts that the ARRT tests directly. Vertebral levels and landmarks. C1. The atlas. Ring-shaped, no vertebral body, no spinous process. C2. The axis has the odontoid process projecting superiorly. C3 through C6. Typical cervical vertebrae with bifid, split, spinous processes. C7. Vertebral prominence. The longest spinous process, palpable at the base of the neck. Prevertebral soft tissue, measured on the lateral. Normal widths, C2 through C4, 5 to 7 millimeters. C5 through C7, up to 20 millimeters. Widening indicates hemorrhage, edema, or abscess in the retropharyngeal space. This is a critical radiographic finding. Report immediately. Atlanto-axial relationship. Predental space, the distance between the anterior arch of C1 and the odontoid process. Normal adults, 3 millimeters or less. Children, 5 millimeters or less. Widening indicates rupture of the transverse ligament, as in rheumatoid arthritis. Cervical alignment on lateral. 3 smooth lordotic curves should be traceable. The anterior vertebral body line, posterior vertebral body line, and spinal laminar line. Any step-off or break in these lines indicates fracture or subluxation until proven otherwise. Trauma protocol. Cross-table lateral first. AP axial second. AP open mouth third. Add obliques and flexion/extension only after physician clearance. The bar chart shows relative MES adjustments for different patient types. Post-fusion hardware requires the most significant increase, approximately 45% above standard, to penetrate metal implants. Pediatric patients require dramatically less MOS than adults. 5 major cervical injuries. Jefferson fracture, burst fracture of C1 from axial loading, like a diving injury. The C1 lateral masses are displaced outward bilaterally. Best seen on the open mouth view, where the C1 masses appear wider than the C2 body. Odontoid fracture. Types 1, 2, and 3. Type 2, through the base of the odontoid, is the most common and most unstable, seen on open mouth and lateral views. Hangman's fracture, bilateral fractures through the pedicles of C2 from hyperextension. Best seen on the lateral cervical radiograph, associated with motor vehicle accidents. Clay shoveler's fracture, avulsion of the spinous process, most commonly at C6, C7, or T1. On the AP view, the double spinous process sign may be visible. Teardrop fracture, severe flexion mechanism, the anterior inferior corner of a vertebral body avulses. Highly unstable, associated with spinal cord injury. The most serious cervical fracture pattern. 3 cervical spine questions. The answer is B. Upper incisors and base of skull superimposed. For the AP open mouth view, the upper incisors and the base of the skull, the occiput, must be superimposed. This alignment confirms the CR is perpendicular to the C1, C2 level with the mouth open, projecting the odontoid process between the C1 lateral masses. If the chin is too elevated, the occiput overlaps the odontoid. If too depressed, the teeth cover it. The answer is B. Depress shoulders and repeat, or obtain a swimmer's lateral. All 7 cervical vertebrae in the C7, T1 junction must be demonstrated on every lateral cervical radiograph, especially in trauma. An assistant gently pulling on the patient's wrist depresses the shoulders, often uncovering C7. If that fails, the swimmer's lateral projects through the shoulder girdle. The C7 T1 junction is one of the most clinically important levels. A study is incomplete without it. The answer is C. Hangman's fracture, bilateral C, two pedicle fractures from hyperextension. The Hangman's fracture involves bilateral fractures through the pedicles of C2 caused by hyperextension and distraction. It is best seen on the lateral cervical radiograph. Jefferson fracture involves burst C1. Teardrop involves flexion and anterior corner avulsion. Clay shovelers involves spinous process avulsion. Lesson 9 complete. AP axial for C3, C7 with 15 to 20 degrees cephalic angle. Open mouth for the odontoid with incisor-occiput superimposition. Lateral at 72 inches with the 7 vertebrae requirement. Swimmers for C7, T1. Obliques for foramina. Flexion extension for instability. Prevertebral soft tissue measurements. Atlantoaxial predental space. And 5 major cervical fracture patterns.